Okay, so we're going to get started. I am recording, and hopefully this will work. We're going to talk about patients with acute respiratory problems. And the first thing we're going to do is go over a few definitions of things to kind of review, because a lot of the stuff that we're going to be talking about in terms of different respiratory disorders are going to be based on the fact that patients have issues with some of these processes of ventilation or perfusion. So what's the definition of ventilation? Just very simply, moving air in and out. So some patients may have difficulty moving air in and out of the lungs. And then we have diffusion. Where does diffusion take place? At the alveoli capillary level. So some patients may have no problems pulling the air in and out, but once the oxygen gets into their lungs, they're not getting good diffusion of that oxygen into the capillaries through the alveoli, and then the receiving of the CO2 when and the deoxygenated blood when it comes back. So patients can have ventilation issues, they can have diffusion issues. And then where does perfusion take place? At the tissues. So patients can have some issues and problems with gas exchange. They may be able to ventilate, and they may be able to diffuse at the capillary alveolar level. So their respiratory system is working fine, but maybe there's some cardiovascular and circulatory issues that's causing problems with perfusion. Or, and that a lot of times will be related to things like decreased cardiac output. What Pat was kind of alluding to was that when we hyperventilate and are constantly pumping air into a patient that's on a ventilator, we're increasing the intrathoracic pressure, we're lowering cardiac output, and then we may have some problems with perfusion, end organ perfusion, just because of the fact the patient's on the ventilator. So you all know the regulation of the breathing is at the controlled by the medulla and the pons, and it's stimulated by elevated CO2, hypercapnia, except in those patients with COPD, where their stimulus is hypoxia. And that's why with our patients, we're not going to give them any more than 2 liters of oxygen until we find out, is this a COPDer? So that patient coming in with respiratory distress and you don't know any history, it's safe to put them on 2 liters of oxygen. But then we got to find out, are they on COPD? Because if we crank up the oxygen too high because we want that nice oxygen sat at 95%, we could stop them from breathing if they're a COPDer. Now, of course, the textbook always says, 2 to 3 liters, that we kind of had drummed into our heads in nursing school. But how many of you seen chronic COPDers with oxygen at maybe 3 liters or 4 liters? If they can tolerate it, you can titrate it. But you just have to have that awareness that you just can't crank it up on that COPD patient, and you're going to risk stopping their breathing. So now we got the patient comes in with some health issues, respiratory issues. So what kinds of questions, when you're taking that health history, are you going to ask that patient to help the doctor with that diagnosis? Do you smoke? Yeah, that's always the big issue. So you've got the tobacco pack year history. So even if they quit smoking several years ago, if you know that they smoked 2 packs a day for 20 years, there's going to be some residual effects. What else are you going to ask them? Why is that important? Right, so exposures to certain carcinogens in the workplace, asbestos being a big one that a lot of people had before they realized how toxic asbestos was. And so, inside of a factory, what types of chemicals and other types of things that you're exposed to, or if they work outside and they may have environmental allergies that they're not even aware of, and they're outside working and there's pollen and dust and all kinds of, and mold in the air, grass, all that thing can aggravate that patient. So knowing where they are, where they work, where they live is going to be very important. What else?
What hobbies do you like to do?
What hobbies do you like to do? Because? Glues, fumes, paints, all of those things can, patients are inhaling them and they can aggravate and damage their lungs. What else you're going to ask them? Recent exposures to anything. Okay, so did they travel out of the country? Were they exposed to some sort of respiratory pathogen when they were out of the country? Do they live in a crowded community where they might have been exposed to tuberculosis? What other kinds of things? What's that? The length of the respiratory systems. How long has this been going on? What precipitated it? Are you on any meds for it? You know, do you take any over-the-counter meds? Do you take any prescription meds? How do you use your inhalers? That is a huge thing. Patients oftentimes do not use their inhalers properly, and they can actually aggravate their respiratory condition by improperly using their inhalers. In home care, I would go out and do an admission visit on a patient with chronic COPD, and they'd have their bag of inhalers sitting, like stacks of inhalers, all of them outdated usually and really looking kind of disgusting. And they'd be sitting there, and they take their inhaler that they're supposed to use twice a day, and they use it 3 or 4 times while I'm talking to them and doing the interview, and I'm like, how are you supposed to take that? Well, whenever I get short of breath. No, because now you're having a rebound effect from that inhaler, and it's actually making your asthma or your COPD worse. So are they using their inhalers correctly? What else do you need to know? Yes? Exposure to second and third hand smoke. So, do they live with a smoker, but they don't smoke themselves? Any allergies that they might have, either medication allergies or environmental allergies. Over-the-counter drugs that can affect respirations. And then, when did you have your last chest x-ray? Have you had a TB test lately? All that's going to be part of your history when you're trying to gather the data to find out what could be causing this respiratory issue on my new patient. And then you're going to do a focused respiratory assessment. So what's that going to consist of? Breath sounds. What else? The respiratory rate. The depth, what? Capillary refill. What's that? Chest configuration. Do they have an expanded anterior-posterior diameter, an AMP, which would be in what type of patient? A COPD or an emphysema patient. So they got a lot of dead air in there, in their alveoli, and their lungs, their chest expands, so they get that barrel chest. Do they have equal lung excursion? When they're breathing, do both sides, the ribs come out equally, and you're hearing breath sounds on both sides. That's really important when you're talking about that patient on a ventilator, because if you're only hearing breath sounds in the right lung, then you know that your endotracheal tube has been misplaced and it's not ventilating both lungs. So all those things that you learned back in your assessment in Nursing 100, use of accessory muscles, nasal flaring, clubbing, all those things are going to be part of your focused respiratory assessment. Now, I know most of you are not all stressed out about ABGs anymore because you had Michelle who taught you the tic-tac-toe and figuring out your ABGs and whether it's metabolic or respiratory and all that. Because there's so many different mnemonics that people use, and Michelle showed me the tic-tac-toe thing once, and I haven't really, used it. But what I'm going to talk about is not what you would necessarily be tested on in terms of an acid-base imbalance NCLEX question that's focusing purely on acid-base. I'm going to tell you how to look at some of those NCLEX questions where you have a scenario about a respiratory patient and they throw up a set of blood gases, and you need to know what's normal, what's abnormal, because it could be a distractor or it could have something to do with the question that you need to know to answer the question. And then they'll ask you things like, well, is it respiratory acidosis? Is it alkalosis? And by the time you finish reading the question, your brain's going around in a bunch of different directions. So this is kind of the quick and easy approach to looking at those questions and giving yourself the best chance to answer that NCLEX question about ABGs. You have to know the normals. You got to know them. They expect you to know those. There's certain lab values that NCLEX expects you to know and have memorized. pH 7.35 to 7.45, PCO2 35 to 45, bicarb 22 to 26. You might see that slightly different. Some hospitals it might be like 21 to 27. I mean, you'll have slightly different averages and norms depending on your hospital. And your partial pressure of oxygen 80 to 100. Not to be confused with your pulse ox, which is expressed in a percentage, which if it was 80%, you'd be really worried about. So be real careful on those NCLEX questions to see that they're talking about your partial pressure of oxygen 80 to 100 versus, or are they talking about your oxygen saturation expressed in a percentage. Now I have posted on Blackboard interesting respiratory links, and I know from from experience that most of you don't look at these because, and aren't even curious as to why I think they're interesting. But they're there, and when I talk about chest tubes and chest traumas later on in this unit, there are links to the videos that I'm going to show in class so that you can actually see them again. It just takes a little bit of time to load. Or not. Okay, let's try it again. Worked yesterday. There we go. So this talks about acid-base balance and why is it important for us to know about how acid-base balance affects the patient's health. And basically what our body is constantly striving to do, and you've all had this in Nursing 200, Michelle talked about it, your body tries to keep the pH between 7.35 and 7.45. It has a lot of different compensatory mechanisms that it uses to get that balance. So that's where we want, that's what's called homeostasis, where our health is in balance. So it's kind of like the guy on the tightrope. And when he's at 7.4, which is within the normal range, he's pretty good on that tightrope, but if we move it to 7.48, a little bit alkalotic, right? He's getting a little unsteady, and if we move it up higher, he's really having trouble staying on the tightrope, maintaining homeostasis, and we get to 7.6, and he falls off the tightrope. I'll put him back on there. I feel bad for him. Okay, then we go down to 7.3, which is what? Acidosis. And he's a little wobbly. And then we go to 7.28, which is right around where we're going to have to put him on a vent. He's fallen off that tightrope. So that's one of the interesting respiratory links. The other one talks about just a quick way to look at a clinical scenario or look at a disease that they talk about, and you can guess, oh please, you can figure out what type of acid-base imbalance based on that clinical picture. So there's 4 different types of acid-base imbalances. First one is respiratory acidosis, and that happens when the lungs can't get enough oxygen. So all of your patients with COPD, with pneumonia, anytime that they can't get enough oxygen into their lungs, they're going to be in respiratory acidosis. Their CO2 levels are going to rise because when you dissolve CO2 in water, it creates an acid. So when you got too much CO2, you're in acidosis. Respiratory alkalosis is if you're blowing off too much CO2. So that would be the person who is hyperventilating. Metabolic acidosis, remember the 3 Ds. The 3 conditions that it most commonly will cause that patient to become acidotic metabolically. And that would be diarrhea, diabetic ketoacidosis, and dialysis or renal failure. So if you remember those 3 Ds, and that's in that scenario on that NCLEX question, that can help you to determine, okay, I've got metabolic acidosis that I'm expecting that pH to be low. And then metabolic alkalosis is when too much base accumulates. And usually that's when the patient has a lot of vomiting, they're losing acid out of the stomach, or copious NG tube drainage, losing a lot of stomach products and with the acid, and they become alkalotic. So the student is nervous about a big test. Student is panting, says, I feel dizzy and lightheaded. Are they, what acid-base imbalance are they in? Respiratory alkalosis, right? Because what are they doing? They're hyperventilating, they're blowing off too much CO2. And see, it tells you that's correct. Gives you feedback. Patient with kidney failure misses the dialysis treatment, complains of feeling very sick. Metabolic acidosis. Remember the 3 Ds for acidosis. Metabolic acidosis. 85-year-old man had a bad cold. After 2 weeks, he says it went into my chest, it feels tight, I'm coughing and I can't breathe. What do you expect him to be in? Respiratory acidosis. Again, he's not getting enough oxygen, he's building up too much CO2. And finally, the post-op abdominal surgical patient has an NG tube for 3 days. The nurse caring for the patient says there's so much drainage in the tube, I wonder if that's why he's feeling sick. What do we got? Metabolic alkalosis, because why? Losing too much acid out of the stomach. Okay, see, interesting respiratory links. Very interesting. Okay, so we're going to do some ABG practice examples, and those are not in, it's not in your PowerPoint, so don't be flipping through your pages thinking that it's there. What we're going to do is we're going to look at a set of blood gases, and we're going to say, okay, just based on the blood gases, what do you think is the problem? And the easiest way to do this is first look at the pH, because that's going to tell you whether it is acidosis, alkalosis, or normal. And then look at the CO2. Because if you are acidosis and you have a high CO2, then you know you've got a respiratory problem. If you've got acidosis and your CO2 is normal, then you can probably have a very safe guess that it's metabolic in origin. So those two values right there can answer most of your NCLEX questions as to what type of acid-base imbalance the patient is in. So what do you think your interpretation is? What's the pH telling you? We're acidosis. What's the CO2 telling you? It's high, so it's probably respiratory acidosis, right? Now you can look at the PO2, that kind of confirms that we got a respiratory problem. And you can look at the bicarb, which is normal, so the patient's not compensating. And the O2 sat is not looking too good. So this is a 60-year-old male with pneumonia, dyspnea, fever, and chills. So what do you think would be the appropriate interventions? What do you expect is going to be ordered for this guy? Antibiotics. What else? Oxygen. What else? Antipyretics. What else? Fluids. Cough and deep breathe. Yeah, we said that. How about something that's going to help to open up his airway, like a bronchodilator, nebulizer treatments? Okay. Okay, what do we have here? pH of 7.28. Acidosis or alkalosis? Acidosis. CO2 is 43. Normal, high, or low? Normal. So what do you think, just looking at those two? It's probably metabolic acidosis, right? And that's going to confirm, you're going to confirm that by looking at the oxygen. The oxygen looks good, so you know you don't have a respiratory problem. The O2 sat is really good. Again, you know you don't have a respiratory issue. You have a 24-year-old female with Crohn's disease and a 4-day history of bloody, watery diarrhea. So what are you going to do for this patient? Imodium or some other medication to stop the diarrhea. What else? IV fluids for fluid replacement. What else? Pain medication. What? No, most patients with Crohn's disease are going to need some sort of steroid treatment, usually to reduce the inflammation. And given the fact that she's had a 4-day history of bloody diarrhea, what do you anticipate you might have to give that patient? A blood transfusion. So at the very least, you're going to be doing a CBC to see where the H&H is and probably doing a blood transfusion. Okay, 7.02. Acidosis or alkalosis? Okay, CO2 is telling you what? It's high, so it's probably respiratory. O2 is 77. Look at the bicarb. Very low. So we probably have a combination of a metabolic and a respiratory problem on this patient. That's not going to come up on an NCLEX question because they're going to be a little bit more specific and definitive as to whether it's respiratory or metabolic and not give you these combinations. So this patient has urosepsis, confusion, and shortness of breath. So the urosepsis, which is probably going to turn into septic shock very soon, is contributing to that metabolic acidosis that the patient's experiencing. The shortness of breath probably related to some sort of a respiratory issue that's causing him to retain CO2 and adding a respiratory component. So we got urosepsis, confusion, and shortness of breath. What are we going to do for him? Oxygen. With a pH that low, mechanical ventilation. He's a sick puppy. What else? Antibiotics, because we want to treat the urosepsis and any underlying respiratory infection that might be there. What else? Fluids? Oxygen, mechanical ventilation, yeah, with PEEP probably. Potentially what?
Potentially a one-on-one, depending on how the confusion is and if he's agitated.
Right, so yeah, one-on-one, somebody doing, one-on-one observation for him because of the confusion. But with a pH of 7.02 and with those blood gases, he's probably not going to be too frisky trying to get out of bed at that point. Okay, pH is 7.37. Is that normal, high, or low? It's normal. CO2, if 63. High. So what would you expect this patient to be in? Respiratory acidosis, right? With a CO2 that high, but the pH is normal. So it is, I heard somebody say it, compensated respiratory acidosis. Compensated because the pH is within the normal range, but by looking at that CO2, you would expect them to be in acidosis, respiratory acidosis, so you're saying it's compensated respiratory acidosis. And that's why the bicarb is so high. The bicarb is high to compensate for that respiratory acidosis. But the only thing you really need to know is your pH and your CO2. So compensated respiratory acidosis. This patient is a 61-year-old female with COPD. What are we going to do for her? Nothing. Why aren't we going to do anything? Why not give her oxygen? Right, this is where she lives. Giving her oxygen is going to get rid of that hypoxic drive, and she's probably going to get worse. This is her baseline. I have seen patients in the hospital with ABGs like this sitting up and talking to me, watching TV, and the student freaking out because they pulled the ABGs off the printer and they're going, holy, they're running down to the patient thinking they're on the verge of death. And I said, you missed an important thing. You missed what the pH was at. Because if they're compensated, that's their baseline. We're not going to do anything to upset that little apple cart. But she's going to bear watching because if she comes in for some other problem, she can decompensate very quickly if we don't watch that. You can tip her right into respiratory failure very, very quickly. Because you can see that pH is right down at the low end of normal. It's not going to take much. pH is 7.5. What do we have? Alkalosis. What's the CO2 telling us? It's normal, so what's our guess? Metabolic alkalosis. 17-year-old female with intractable vomiting. Perfect classic case. So what are we going to do for her? Antiemetics, fluids, and electrolytes. Intractable means that it's uncontrolled. Anything that's intractable is not good. Intractable pain, not controlled with pain meds, intractable vomiting. So those women that have that hyperemesis in the early stages of pregnancy, you could also refer to that as intractable vomiting. It just, nothing you give them stops the vomiting. So antiemetics, fluids, and electrolytes, and get her stabilized. Okay, pH of 7.46. Slightly high, so we're in alkalosis. CO2, normal, so what's our guess? Metabolic alkalosis. This is a 55-year-old male with GERD who takes 15 Tums per day. So what are we going to do for him? Take away his Tums, but he's still got GERD, so what else are we going to do for him? Put him on an alternative medication, histamine blocker, proton pump inhibitor, right? Maybe check him for H. pylori, because a lot of patients who have what they think is GERD is really an H. pylori infection. They treat the H. pylori, and the patient doesn't need to go on all these meds. But we got to get him off those 15 Tums. He's got really strong bones, but not a good thing. Okay, pH 7.0. What's happening? We have acidosis, right? We have CO2 of 59, which tells us we have what? Respiratory acidosis. But our O2 is 86, so that's not really that bad. So I'm thinking there's got to be something else going on as to why his pH is so low with a 59 CO2, but a pretty decent partial pressure of oxygen, and a 91% O2 sat. But look at his bicarb. Very low. So he's got a combination. This is one of those combination patients. A combination of some respiratory and metabolic components that's dragging down the pH. So this is a patient with type 1 diabetes, so there's one of your 3 Ds, and also pneumonia. So the combination, and maybe got the pneumonia first and then that aggravated the diabetes and he goes into diabetic ketoacidosis. So what are we going to do for him? A lot of stuff. What are we going to do? He's got a 7.0 pH. Where do you think he's going to be ventilating on? On a ventilator. What else are we going to do for him? Antibiotics, bronchodilators, treat the diabetes, so an insulin drip, all kinds of good stuff. So that's how you can approach these kinds of questions. Know your normals, look at the pH first, then look at your CO2, and that's going to help you answer the majority of your NCLEX questions that are going to have ABG components to them. And now we're going to prioritize, because again, that's a lot of that on the NCLEX. We have an adult patient admitted with acute exacerbation of COPD. His heart rate is 108, respiratory rate is 26, blood pressure 144/76. Temp is 100.8, pulse ox is 89%. His orders are O2 at 4 liters, D5LR at 75 milliliters an hour. His position of choice is sitting up on the edge of the bed, leaning over the bedside table. What do we call that? Tripoding. Why do they do that? How does it help them breathe? Right, and so yeah, when they're up like this, it opens up their lung, expands their chest cavity, so it helps them breathe better. So now we got new orders, and we need to place the following new orders in order of priority. So remember these, and what we have going here. We have Tylenol, Rocephin, increase O2 to 6 liters, ABGs on 4 liters, obtain sputum cultures, nebulizer treatments 4 times a day. So what are we going to do first? Why are we doing the ABGs first? Because he's on 4 liters and the order is ABGs on 4 liters, right? So a lot of you wanted to just crank up the oxygen first, but you've got to read the orders. ABGs on 4 liters. Then what are you going to do? Remember ABCs. Then we're going to crank up the oxygen to 6 liters. So we got to get the ABGs first on 4 and then bring them up to 6. Now what are you going to do? Why are you going to do that first? So it's going to help the neb. And what's the neb treatment going to do for some of the other orders that we have? Loosen up the secretion so we can get that nice juicy sputum specimen that grosses me out. I hate sputum. So we're going to do the neb treatment next, and then what? Are we going to do the sputum culture or the Rocephin? Why do we have to do the sputum culture first? Because you have to get the culture before you give the antibiotics. Any kind of culture that's ordered, if they're not already on antibiotics, you've got to get that culture first and then do your antibiotics. So get the culture and then do your Rocephin. Tylenol is the last thing, that I really care about on this patient. This is I got to be ambidextrous because I can't reach my left arm up. There we go. So that's our last one. So you will see many kinds of NCLEX questions that have you put the steps in order of priority. You'll see at least a couple of those on all of my exams. Awesome. Yeah. And a lot of select all that apply. But remember, we have a strategy for that. And if you use it, you will get those questions correct. Okay, first we're going to talk about acute respiratory failure. And there's a couple of different significant respiratory diseases that we're going to talk about. There's acute respiratory failure and there's ARDS, and there's significant differences between what causes the two of those different processes. So the first thing we're going to talk about is acute respiratory failure. So they get diagnosed with that if they have hypoxemia with a PaO2 of less than 50 and or hypercapnia, a PaCO2 of greater than 50, plus a pH less than or equal to 7.35. So they got to have at least 2 out of 3 to be considered in acute respiratory failure. How does this differ from chronic respiratory failure? What does the book say about that? What's the definition of chronic respiratory failure?
COPD.
Yeah, so a chronic respiratory disease. So what does that mean? How does that differ from an acute episode? Right, you're compensating, you don't have acute symptoms, you're just, like as you said, that typical COPD patient oftentimes is what you would consider a chronic respiratory failure because of their status and because of the way their ABGs are presenting. But they can become acute very quickly. And you've got a couple of ways that I always want to say acute renal failure because ARF kind of sticks in, acute respiratory failure. You can have it as a result of alveolar hypoventilation. So what are some of the things that are going to make it hard for the patient to ventilate? What kinds of conditions are examples of that? What's that? That's more under the diffusion area where there's not, where you're not diffusing at the alveolar level. But what can make it hard for that person to just move air in and out of their lungs? Remember we talked about what's that? Pain, neuromuscular disorders, obesity. So anything that affects the ability of the lungs to expand and contract and bring air in and out, ventilation, can cause or lead to acute respiratory failure. Patients can also have diffusion abnormalities. And oftentimes patients with acute respiratory failure have combinations of both ventilation and perfusion or diffusion. So what are some of the reasons? Somebody talked about decreased surfactant. What are some other reasons why the patient's not able to diffuse at the alveolar capillary level? Pneumonia. Emphysema, so COPD, smoke inhalation, so inhalation of toxins. So anything that alters your alveolar perfusion can lead to acute respiratory failure. Patients can also have ventilation perfusion mismatches, where the air movement is normal, but the perfusion is not adequate, or vice versa. And oftentimes that can happen with things like shunting, left-right cardiac shunting, or increased dead space. Those patients with pulmonary emboli, with COPD, that have areas of their lungs that are the air is just sitting there and it's not moving in or out. The causes, decreased respiratory drive, and we talked about some of the reasons why that patient may not be able. What's the stimulus for respiration, and how can it be affected? So high CO2. So if the body's chemoreceptors are not sensing that they have high CO2, there's some sort of a malformation, a malfunction in the brain or the central nervous system, some neurological deficit. Any medications can all cause that patient to have a decreased respiratory drive because their body is not sensing that higher level of CO2 and responding to that. Chest wall dysfunction, paralysis, neuromuscular diseases, spinal cord injuries. Lung parenchyma dysfunction, the lungs can't expand. And that's right at the actual lung tissue level. So traumas, pneumothorax, hemothorax, anything that's going to affect the ability of the lungs, you've got that negative pressure that helps the lungs expand and contract. There's things that are impeding that, and we're going to talk about some of the traumatic issues later on in this unit. So what's our treatment? What's the medical and nursing management of that patient with acute respiratory failure? Oxygen, usually mechanical ventilation. Treating that underlying problem. Trying to correct that diffusion issue, that ventilation problem. And without those patients with a chronic neurodegenerative disease that we're going to talk about in a few weeks when we go into neuro, there's not a whole lot we can do to correct that underlying neurological problem, so we have to give them respiratory support as they continue to deteriorate. And our nursing management is going to be all those respiratory assessments and cardiac assessments that we talked about. So that's acute respiratory failure, so problems with ventilation and diffusion at the alveolar capillary level. Then we have ARDS, acute respiratory distress syndrome. Totally different pathophysiology from acute respiratory failure, because this is a systemic inflammatory response. We have a very severe inflammatory response. Now, what happens normally when you have an inflammatory response? What does your body do? What does it send? What does it deliver? What does it create? A little bit of an A&P review here. Right, histamine, macrophages, chemical mediators, interleukin, all that kind of stuff that goes to help to heal that area of that the body is sensing has some inflammation going on. So in this particular case, you have a severe systemic reaction, inflammatory response. And that causes a release of those inflammatory mediators, but at very high levels. And what they do is they damage, because we're talking about lungs, they damage the alveolar capillary membrane, which makes it more permeable. And when you have increased capillary permeability at the alveolar level, you're going to have leakage of fluid out of the intravascular space into the alveoli, causing non-cardiogenic pulmonary edema. And that is key, because this patient's heart can be functioning just fine. And the pulmonary edema that they're experiencing isn't because of what-sided heart failure. What-sided heart failure backs the blood up into the lungs. Left-sided heart failure causes lung crackles and fluid accumulating in your lungs. But this patient may have a perfectly well-functioning heart. The fluid in their lungs is because of that capillary leak, non-cardiogenic pulmonary edema. And then that causes microatelectasis. What is atelectasis? Collapsed lung. So the alveoli collapse, the capillary membrane is damaged. That's where the surfactant is produced. And if you don't have surfactant, then the alveoli collapse and they stick. So you have decreased compliance and decreased surfactant, and everything just kind of collapses and sticks. And then the result of that is severely impaired gas exchange. This is a patient who is going to be on a ventilator when they have ARDS. They cannot perfuse because of all that junk that's accumulating in their lungs. So there's a box on page 299 talks about the common causes of ARDS. So what kinds of patients are going to be at risk for ARDS? Why would people who travel? Why? No, you're thinking SARS. Right, severe pneumonia that sets up that, because it's got to be something that's going to cause a systemic inflammatory response. Sepsis. That patient that goes into septic shock is going to be at a very high risk for developing ARDS, because the septic response is a severe systemic inflammatory response, and we're going to talk all about that when we get into shock and sepsis later on. Patients who have had massive blood transfusions. Why do you think a massive blood, and we're talking like more than just a couple of units, we're talking 5-10 units of blood with a major trauma. Why do you think that patient would be at a high risk for developing ARDS? The increased fluid volume. And if you've got capillary leak in the lungs, the body is responding to this trauma with a systemic inflammatory response. You've got capillary permeability at the lung level, and now you're pumping them full of blood, and that increased pulmonary hydrostatic pressure, doesn't that sound good? It's one of the few technical things that I talk, pushes that fluid into the lungs, causes that non-cardiogenic pulmonary edema. Pancreatitis, your patient that comes in with pancreatitis, very high risk for getting sepsis and then becoming affected with ARDS. So a lot of different reasons that patients can have and develop ARDS, and it's really a severe, emergent type of lung condition where they're going to be on a ventilator, and it's a really tough course of treatment. Anaphylaxis, because it is a type of shock that will cause capillary permeability, yes. Yes?
So why pancreatitis? Would appendicitis also?
Not really. A pancreatitis is such a nasty infection that patients are at a very high risk for developing sepsis. I mean, obviously, if you had appendicitis that ruptured and you got peritonitis and you had a really massive infection going on, then yeah, then you can become septic. But because the pancreatitis is such a severe inflammation, and the fact that it's kind of right up underneath the diaphragm, it's kind of close to the respiratory areas, you know, you're not breathing deeply, you know, it's a much higher risk of getting ARDS from that. Yes, Kate? Why prolonged? Because it affects it damages the alveoli. So what respiratory symptoms do you think you're going to see in a patient with ARDS? What are you going to be hearing? What are you going to be seeing? Crackles, because they got fluid, non-cardiogenic pulmonary edema. Dyspnea, tachypnea. What do you, somebody's... Respiratory alkalosis. Why are you going to see respiratory alkalosis, Justin? Because what are they going to be doing? You're going to see that initially. Because why? Because they're hyperventilating. They're trying to bring in more oxygen and blow off more CO2. So they hyperventilate initially. Their ABGs are going to show respiratory alkalosis, but they're going to deteriorate so quickly. They're going to go into respiratory acidosis, and they're going to go into metabolic acidosis, which I'll explain a lot more when we get into shock and sepsis. But basically, what's happening is that the oxygen levels drop. Remember the Krebs cycle? The cells go into anaerobic metabolism and increase lactic acid. We're going to talk all about that in a few weeks. You're just going to be flashing back with bad memories in A&P. VQ ratio, ventilation perfusion. I don't know why they say Q, why don't they say P, but it's VQ ratio, and it should be right around 1. But what will happen is that you'll have an imbalance of the ventilation perfusion ratio in that patient with ARDS. What about the temperature and the pulse? What do you think are going to be changes for that? Increased temp, increased pulse. You've got an inflammatory response, and when you've got inflammatory response and you've got shock and you've got all that other stuff going on, the heart rate's going to increase because your body is screaming for oxygen. What do you think, are there going to be any EKG changes or hemodynamic changes? It's non-cardiogenic. So their EKG is going to be usually their baseline. So they may have some changes, you know, I mean, they may have something off on their EKG, but that may be their baseline. Same thing with hemodynamics. If there's no cardiac issues, it's a pulmonary problem, then their EKG, their hemodynamics should be relatively stable, unless they have other underlying issues. And then their x-rays are going to get worse and worse and more cloudy, what they call whiteout, as the fluid fills up the lungs. And that's what those lungs are going to look like. That's a patient with ARDS. And when they have complete whiteout, you'll see all the way up the entire lung, both sides, is all that. Some doctors will refer to it as ground glass appearance. And yeah, this patient's going to be on a ventilator because they cannot perfuse. Yes? Increased tachycardia, because anytime you're not getting enough oxygen, that's one of the compensatory mechanisms your body uses to try to get more oxygenated blood to your body. True. Oh yeah. These are sick puppies. This is a picture from the Iggy textbook that shows the alveoli filling up and the hyaline membrane that produces the surfactant getting damaged, and one of the alveoli collapsing and filling up with all kinds of fluid. It's lovely. So what's our treatment? How are we going to administer oxygen to this patient? Ventilator with PEEP. What medications do you think we're going to give him? So we have an acute inflammatory issue going on, so what do we usually give for inflammation? Steroids, Solumedrol, corticosteroids, antibiotics. Are we going to give diuretics? Yes, yes, with a big but. What's our big but? Why do we have to be careful with the diuretics? Right. But remember, we don't have cardiogenic edema going on. We don't have a systemic edema. If you give diuretics, yeah, it can help to pull out some of that edema in the lungs, but it could also dehydrate the patient systemically. So diuretics, if they have really severe pulmonary edema, but we've got to really watch them hemodynamically, because if we dehydrate them, because remember, it's a non-cardiogenic issue we have going on there. They're going to be on a ventilator probably for a week or so, so how are we going to feed them? TPN, and eventually, if they're on the vent for a longer period of time, what do we have to do? A PEG tube, because TPN isn't going to give them the complete nutrients that they need for any kind of long term. So the indications for mechanical ventilation, very similar to the ABGs that we saw for that patient with acute respiratory failure. Hypoxemia, the PO2 less than 60. Hypercapnia, PCO2 greater than 50. Respiratory acidosis, a pH of less than 7.25. So a lot of those examples that we talked about on those ABG questions, those patients would have to be on a ventilator just based on their pH. If the CO2 is equal to the O2, but remember, they also have to have a bad pH, because you could have that COPD that's got a 60 CO2 and a 60 O2, but their pH is okay and they're compensated. So again, you're not going to get all worried about putting them on a ventilator. And if they have a respiratory rate of greater than 35 per minute. So those particular clinical indications, and what are some of the situations that we might see a patient have to go on a ventilator? When do we see patients on vents? What's that? Traumas, post-op, anytime they have any kind of general anesthesia or heavy sedation. Now there's a couple of different types of ways that we do ventilation to patients. There's invasive and there's non-invasive. So there's a couple of non-invasive positive pressure methods of delivering ventilations. And that's CPAP, which means what? Continuous positive airway pressure, and BiPAP. So these are ways that patients may have some short-term ventilatory support. They don't need to be intubated. They don't need an endotracheal tube. It can be delivered by a nasal cannula or a mask. So where do we see CPAP used a lot? With sleep apnea. Because that continuous positive pressure, think of it as the ventilator's pushing air into the lungs, and it's a continuous positive pressure even when the lungs are deflating and when the patient is exhaling, because it's keeping those alveoli open. BiPAP, similar to CPAP, it's just different levels of pressure between the inhalation and the exhalation part of that ventilator state. So two ways that patients can be ventilated without having to have an endotracheal tube. But if they do need an endotracheal tube, it's not something you're going to have to learn how to do unless that's something that, you know, some kind of specialty area that you want to do, like if you want to become a CRNA or something. And why do we need that endotracheal tube? Why do we bother to put one in? Maintain an airway. For that patient who can't maintain an adequate open airway, how else are we going to use that, or why do we use that? Protect from aspiration and allow us to suction if they have copious secretions. So we're going to ventilate during the preparation, because that could be part of your job as the nurse working in that acute scenario. The head of the bed is going to be flat during the actual intubation process, and then the head of bed is going to be immediately raised up to at least 30 degrees, and as Pat said, now they're talking with protocol up to 40 to prevent aspiration. They'll usually spray a topical anesthetic and maybe even administer a paralytic so that they can get the patient to relax and they can get the endotracheal tube back in. what they will do usually is have a stylet in the endotracheal tubes, because it's otherwise without it it's kind of floppy and hard to put it into down the trachea. So they have a stylet which makes it a little stiffer, and they can change the shape of it so they can get it into the patient's trachea. And then they're going to remove the stylet when they know that they have it in there, and they are going to blow up the cuff. So that's the way it's supposed to look. This is the pilot balloon up here, and that's the cuff. The pilot balloon is going to tell you whether or not the cuff is inflated or deflated. So if the pilot balloon is flat, then you know that your cuff is deflated and you've got problems. Number one, it can dislodge, right? What's the other problem that can happen? Aspiration, and what's another problem? Secretions are going to go, so it's aspiration, but what else can happen? If you don't have a good seal, the tidal volume that that ventilator is delivering is going to leak out around that tube. Just like if you don't blow up the balloon in a Foley catheter. If it doesn't fall out, the urine's going to leak around it because the balloon is not sealing it. So the the cuff has to be inflated. And so if you come in, you're not going to be able to see if the cuff is inflated, but if you see that the pilot balloon is inflated, then you know your cuff is inflated. And that's where you're going to hook that, thing that she had that measures the actual cuff pressure. Because as she was saying yesterday, when you're in an emergent situation and you're intubating somebody and you're just going to blow up that balloon as snugly and make it fit as snugly as you can, because you don't want it to dislodge while you're checking placement and all that other stuff. But once they get back to the ICU, you want to check that cuff pressure and keep it between what? 20 and 30 centimeters of water. And that's going to prevent any damage to the trachea. So your cuff has to be inflated. And then you mark it so that you know where it is at the incisor, so that if it slides out, you can see, oops, I made a mark here, but now it's out to here. And then we're going to check for placement. So the best way is a chest x-ray. That's going to tell us that it's in the trachea. These are just some other. But why do we have the common problem of misplacing in the right main stem bronchus? What do we know anatomically is the problem? It's a sharper angle and it's up higher. So if the tube gets twisted when they put it in, it can very easily go down into the right main stem bronchus. So now only the right lung is being ventilated and the left lung's not getting anything. So you're going to have what is called volutrauma, an imbalance of the lungs being ventilated. So you need to find out if it's in if it's in the trachea and not just ventilating. So how are we going to tell that without a chest x-ray? What are some of the assessments? Lung sounds. Can you hear lung sounds on both sides? Do we have equal expansion of the rib cage on both sides? How can we tell if it's in the trachea as opposed to the esophagus? What are some of the ways, other than a chest x-ray, that we can tell? What's their O2 sat? Is their SATs improved? But you can also use, where is it? There it is, an end-tidal CO2 monitor. And what you do is you put that on the end of the endotracheal tube, and when the patient exhales, it changes the color of the paper and indicates that it's in the airway as opposed to in the esophagus. It's the end-tidal CO2. And they may have a different look than this one particular one that I'm showing you. But what it does is it changes the paper in the presence of CO2, changes the color. It may change to blue or pink or whatever it is, the product that you guys might see. And that is going to tell you that it's in the trachea, it's in the airway, not in the stomach. Now we got a patient who's had an endotracheal tube for a while. And now he needs to be trached. What are some of the reasons why somebody would need to be trached? Why don't we just leave the endotracheal tube in? For long-term mechanical ventilation, the trach is much safer, less complications than using an endotracheal tube. So long-term mechanical ventilation, frequent suctioning, or if they have an airway obstruction that no matter, we'll never be able to extubate them. We need to keep that airway open, so we use the tracheostomy. Now, of course, the ideal place to do that would be in the operating room, but if your patient has an obstruction and you can't get an endotracheal tube down there, they may have to do a percutaneous tracheostomy, like you see on Grey's Anatomy, where they use a pen or something, stuff like that. But anyway, and then you have a cuff on the trach, just like you do on that endotracheal tube. But with trach patients, oftentimes you'll have a decision or an order based on whether or not we're going to keep the cuff inflated at all times, or can we deflate it when the patient's eating. And what are some of the reasons why or why not? What would be reasons why we would not be able to deflate the cuff? What's that?
It's not secure with all that.
And that's going to be a problem with any kind of deflation, but there's actual specific conditions that would prohibit you from deflating the cuff ever. The consciousness level of the patient. If they have an obstruction, if the trach is there for an obstruction, then you don't ever want to deflate the cuff, because if it does come out, you may have a heck of a time getting one back in. So it's the reason that they made the trach to begin with is often going to be the thing that determines whether or not we're going to deflate or keep it inflated. That patient that has been on a long-term vent, but we're trying to wean them, oftentimes the doctor will have us deflate that cuff. Because what's happening? What did I just say happens when we don't have the cuff inflated? They're not getting what? They're not getting a good seal. They're not getting the full tidal volume. So that's going to force them to do what? Breathe on their own. Now, and then on some patients that are trach, they may have what's called a Passimura valve that goes on the end of the trach, and that helps them do what? That helps them to talk when they're trached. Excuse me. Now, we're going to talk about the types of mechanical ventilation. But I'm actually going, this is just, it shows the suction catheter that she was showing, the closed suction. And we're going to talk about the types of mechanical ventilation, but I'm actually going to, if I can get out of this, pause my recording. Actually, stop my